Hi, thank you so much for having me speak this afternoon on congenital infectious encephalopathies. This is a very important topic to me. I've been very involved in the evaluation of congenital infections, especially since the Zika epidemic, and I'll talk a little bit about Zika at the end. But this is really a topic that I think we all need to think more about when we're seeing babies in the NICU. So I have disclosures of my grant funding related to Zika. So the objectives of the talk today, we're going to discuss why the term torch is outdated, and I'm going to hope that by the end of the talk you will use different terms besides torch. And I would like to enhance your understanding of congenital infections and how they can really cause disruption to the developing brain. And then I'm going to talk about the presentation, diagnostic evaluation, and potential treatments of some of these congenital infections. I can't possibly cover them all today, though. So congenital infections are likely under-recognized, and because of that, they may not get treated. In some cases, they may be preventable. Just even simple things like encouraging pregnant moms to hand wash more may prevent congenital infections. And they can contribute to substantial abnormalities of the developing brain. So things like destructive lesions that we can see in the brain, such as intracranial hemorrhages, calcifications, reduced cerebral growth, can be because of congenital infections. And then also brain malformations, which I see a lot as a neurologist. So things like schizencephaly or polymicrogyria, cortical dysplasias, these can be due to a congenital infection. And so while they can have other etiologies like ischemic injuries or genetic abnormalities, they can be because of infections. So we really need to be very thorough in our thinking of the etiologies of the different brain conditions that we see. And so I am a fetal neurologist, and so in my practice I am referred many different kinds of cases for evaluation in which there's a concern for the developing brain by prenatal ultrasound. And while it may be hard to read all these different conditions, I want to show that really when I'm seeing a fetus with a concern for a brain abnormality, that for many of the cases, I need to think, could this be a congenital infection? And so I often consider evaluation for congenital infections in my workups. And so the term torch no longer works in 2021. So this is an old term. It was coined in 1971. We all learned this term in medical school. And it used to be a convenient term because it worked with T for toxo and O for other, R rubella, C for CMV, and H for herpes simplex. But the problem is the other list has gotten so long, and as you can see on the left side there, many different viruses go underneath that other term, and of course Zika was added to this list in 2016. And so there's really not a mnemonic to work to describe the different congenital infections. And so really this term is no longer accurate, and since 2014, certainly our infectious disease colleagues have recommended that we do not use this term, and I want to encourage you today to not use this term. And so what I recommend instead that is if a mother had evaluation for congenital infections, or you're going to evaluate for congenital infections in the baby in your NICU, that you specifically state what infections either the mom was tested for or the baby. And so no longer use the word torch titers assessed because we can't really know what that means, and probably not all of the things on the list were checked for. And so we care a lot about congenital infections because they can cause a whole host of sequelae to the baby. And so we can see that most of these, or all of them, really can cause intellectual disabilities. They can cause seizures, blindness, deafness, motor disabilities, learning disabilities. We can see limb deformities in some of them, and so Zika is one of the new ones that has been recognized to cause arthrogryposis. Cardiac dysfunction, hepatic dysfunction, and endocrine dysfunction. And so it's important to recognize these because some may have specific treatments and it really can affect the whole body of the baby. These congenital infections, some of them have given us some hallmark features to help us distinguish. So when we do our workup, we can really target for those that are most likely for our specific case. And so microcephaly, that is one that is more common with toxoplasmosis, rubella, definitely CMV and of course Zika, but also varicella and lymphocytic choriomeningitis virus, which we'll talk about later in this talk as well. Hydrocephalus, that is one that toxo can cause. So while it can cause microcephaly, it can also cause hydrocephalus if those spores are blocking those circulation of the CSF. Zika can also cause hydrocephalus by a similar mechanism. And then the calcifications are an interesting feature of these congenital infections. So of the infections that have calcifications, they have a unique location based on the infection. And so the location of the calcifications for toxo is fairly diffuse around the brain, whereas in CMV, the calcifications really line the lateral ventricles, and I'll show you what that looks like. In HIV, they could be more in the basal ganglia, and then in Zika, it's really in the subcortical region. And then hearing loss is a feature of several of the congenital infections, and so when we see a baby in the NICU that has failed their hearing screen, we need to consider whether this could be because of a congenital infection. And it may actually be the only symptom of the congenital infection. And so in this talk, I'm going to present a couple cases of different infections that have come to us just to really show how these can present. So this was a very interesting referral of a 29-year-old G3P2 mom at 20 weeks and 3 days into her pregnancy. She was sent to us because of fetal ascites, a placental abnormality, and a small fetal head. And the history was very interesting on this one. At 7 weeks into her pregnancy, and this was in the summer, she had a low-grade fever, fatigue, nausea, and headache. Her husband had the same symptoms for about a week. They had a 2-year-old daughter who's healthy. They hadn't traveled anywhere, and she was negative for COVID. So they pursued an infectious workup. Because they live here in the mid-Atlantic, they were tested for Lyme, and that was actually found to be positive. So she and her husband both ended up getting treated for Lyme, which is interesting because certainly it's carried by a tick, and so how the mom and dad would have that at the same time, I don't know. But they were treated for Lyme. Her varicella antibody was positive, but she had been previously vaccinated. Epstein-Barr virus was positive, but that was felt to be cross-reactive due to the Lyme exposure. And so those were the initial infections actually evaluated. And then it was a little bit later into the pregnancy, closer to when she came to see us, that someone checked for CMV. And if you recall the symptoms that she had, kind of that low-grade fever and malaise, that's really how primary CMV can present in an immunocompetent person, just like a cold. And Dad probably had it too, which is why he had the same symptoms. So she was then referred to an MFM for evaluation of congenital CMV. At the MFM, initial fetal ultrasound at 15 weeks, the biometry was normal, but there was a small echogenic focus in the bowel. And then an ultrasound a few weeks later showed a significant drop-off in the head circumference and the biparietal diameter, with a thickened placenta and significant fetal ascites. They did an amniocentesis for CMV and referred her to us for further evaluation. And so here is the fetal MRI in this case at 20 weeks and 3 days gestation. And so this is an axial T2 fetal MRI. And so what we can see on this head is, so this is, so one side of the brain, actually the tissue of the parenchyma looks very dark and thin. And so this is injured cerebral cortex. On the other side of the brain, it's actually kind of thickened and edematous appearing. And so this is undergoing injury on this side. So almost kind of two separate time points of this injury progression for this baby. And we can see this again on this coronal T2. But this goes along with the microcephaly that the fetus is now showing with this smaller head size. When we look at an sagittal image of the baby's brain, we can see the corpus callosum is also short now, so its growth has been disrupted by the infection. And we also can use diffusion-weighted imaging in the fetus. And so we can see that that half of the brain that was showing as edematous is actually bright on our diffusion. So undergoing acute injury. This is another image of this baby, and you can just see the massive ascites and enlarged liver. So this is a very sick fetus with congenital CMV. Here is an image of the placenta. It is very thick and homogeneous. So we also can do brain volume analysis in our cases. And so on the left side is the total brain volume. And I showed you on the images of the MRI, we could see that the tissue was thinned, and we know the baby's measurements were microcephalic. And so that correlates then with this total brain volume at 20 weeks being below the 2 standard deviation mark. However, the ventricular volume was increased, and this is because of the ex vacuo dilation of the ventricles because of the loss of the cerebral tissue with this infection. So the amniocentesis was positive for CMV, and this is primary CMV infection in pregnancy in a very severe case. When I consider babies with congenital infection, it is always important to try and get the placenta. And so if you do have a baby in your NICU that you're concerned about congenital infection, try and get that placenta if you can. So here is placental pathology from a different case, and we can see the inclusions of the CMV here with special staining in the placenta. So congenital CMV is the most common intrauterine congenital infection. It is very important because it causes a huge economic burden. 9,000 infants are affected in the US each year, and it's potentially 1% of all live births. Vertical transmission can occur to the fetus at any age in gestation, but the highest risk is in the first half of gestation. When a mom has the primary infection, like in this case, there's a 30 to 50% risk of transmission to the fetus. But there can also be reactivation. So having prior immunity to CMV does not remove all risk. So you can have reactivation of infection or exposure to a new strain of CMV during pregnancy. And for those cases, the risk of transmission is not as well known, but it's probably about 10%. And so CMV is passed from person to person through close contact with body fluids, saliva being the main one, but others as well. And so, in this case, the family had a baby in daycare, and so that may be they had a younger child, 2-year-old in daycare, and so that may be a source of exposure for a mother that is not previously immune to CMV. And so in daycares, excretion rates can be very high for CMV. So many children in daycare will have CMV at some point. And actually a seronegative mother who has a child in a group daycare setting is at significant risk of acquiring CMV infection during the first year of their child being in that daycare environment. And so this is where preventative measures come in. And so encouraging hand hygiene after diaper changes. Any pregnant personnel should use universal precautions. And then, of course, if you know your sero status prior to pregnancy, you can advocate for increased use of these preventative measures if you know you're seronegative. So this is some nice work done by Dr. Britt looking at the risk of fetal infection and abnormal outcome during pregnancy, whether a mom has preconceptional immunity or does not. And so if it's a primary infection, as we talked about a little earlier, the risk of intrauterine transmission is about 30%. And of those infected, about 10% of newborns will have symptomatic disease, and 30 to 40% of those will be severe. But 90% of babies will be without symptoms. However, it's important to note of these 90%, about 10% later on will develop delayed sensorineural hearing loss or some developmental delays. But for moms that have had exposure to CMV before, and they either have reactivation or are exposed to a new strain, there is still the risk of intrauterine transmission. It is less though, but we don't know that exact amount very well. And if the baby does get infected, we feel that probably it's about 10% of newborns with symptoms, but probably less likely to have the severe disease. And so here, again, these are the calcifications in CMV. And so they really have a hallmark location of being along the lateral ventricles, which is different from the other congenital infections. So CMV diagnosis, it is critical that it's diagnosed early in life because it's outside in the community so much. So a baby that's left our NICU, if we want to test it then, we can't know that it was congenital CMV. So it really has to be diagnosed within the first 3 weeks of life. We usually do this by urine PCR. You could also go back and get the newborn blood spot. So we use a newborn blood spot for our newborn testing. And so that can be a source to check later after the 3-week period. And then we have treatment for it. And so this is one you do not want to miss because we can treat the baby with oral valganciclovir. And this can show a modest improvement in hearing and neurodevelopmental outcomes. They have to be monitored for toxicities and have follow-up audiology evaluations. But it's nice that we have a treatment to improve some of the outcomes for this specific infection. There is a lot of research going on for congenital CMV. For the postnatal period, that we're looking at some new medications, new antivirals, expansion of the treatment to asymptomatic infants. So currently only symptomatic infants are treated. And then we have a study going on at Children's National where if a baby has developed sensorineural hearing loss, we can go back even up to age 4 years of age and go back to that newborn blood spot to see if we find CMV, and we can provide treatment. So I'm going to go to another infection. This is a case that came to us at 29 weeks gestation. It was a homeless mother, and she had of the twins, one had very significant cerebral ventriculomegaly, and the other had a normal brain. And so on this one twin, there was extensive loss of the cortex and white matter. It looked very much like a vascular type of injury. The babies were born near term and actually transitioned pretty well. The placenta had some finding of chronic colitis of unknown etiology. There was testing at birth for congenital infections, kind of the standard ones we thought of, and those were all negative. And so here's the fetal MRI in this case at 29 weeks. And this is such a nice image because we can see a sagittal image of the brain in both twins. And you could see the normal twin here with the brain that is very full, no abnormalities, compared to this twin in which the brain parenchyma is severely atrophic, and there is a lot of additional fluid around the brain in this injury that looks pretty chronic at that point. Here's a coronal image of this fetus again. You could see just very severe loss of the cortical mantle. Postnatally, we could see some calcifications in this case, which were not apparent in the prenatal period. And again, the brain is just very, very atrophic. So this baby came in at a few months of age with concern for seizures, which with the abnormalities of the brain is certainly a baby at high risk for seizures. They did some additional evaluation at that point, including hearing, which was normal, but also an ophthalmology evaluation. And they found these diffuse pigmentary changes throughout the macula that were concerning for congenital infection. And so the earlier infections we checked for were negative. And so we thought some more about this, and LCMV was checked for, so lymphocytic choriomeningitis virus, and was found to be positive. And so this is a single-stranded RNA arenavirus. The common house mouse that is present throughout the world is a natural host for it. It is shed in large amounts in the urine, feces, saliva, and nasal secretion of these little animals. It can also be in hamsters. And then humans acquire it via inhalation of aerosolized particles. And then when the mother is viremic in pregnancy, it can have transplacental spread. Many times a woman can be asymptomatic, or it can present as an aseptic meningitis. But the congenital infection can be quite severe, like the case that I showed you. And we can see just severe structural brain abnormalities, microcephaly, calcifications, retinal damage. Even isolated cerebellar hypoplasia can be because of this. So it doesn't have to involve the whole brain. Sorry. There's no treatment available and only supportive care. But LCMV is present throughout the world. The adult seroprevalence is 5%. So really we should be thinking more of this virus. Sorry. So I'm going to go on to another infection. This is a fetus that presented to us with cerebellar hypoplasia following fetal anemia. So this woman had a pregnancy complicated by fetal ascites, which is found to be due to human Parvovirus B19 infection. There was anemia found at 21 weeks on the Doppler ultrasound, so she underwent intrauterine blood transfusion. And at 23 weeks, the cerebellum was found to be hypoplastic on ultrasound. So she was referred to us for fetal MRI. And so these are images of the fetal brain. And so here we can see the cerebellum, which has a normal contour. But here in these MRI pictures that are taken later, we can see this irregular contour of the cerebellum, so indicating an injury to the cerebellar tissue. This is a postnatal brain MRI now, again showing the abnormal cerebellum. And this is because of Parvovirus B19 infection. So Parvovirus exclusively infects humans. We get it from contact with respiratory secretions and blood. It is pretty common, so 50% of adults have been exposed to this. But again, we get it from those childcare settings where we could be exposed to this virus, and in the US in the springtime is the common time for being exposed. The presentation of this, women, the risk for transplacental spread is about 30% during pregnancy. The highest risk to the fetus for fetal death is in the first trimester. And we worry a lot about severe fetal hydrops. It is about 10 to 20% of all cases of non-immune hydrops vitalis are because of this infection. And this infection can cause significant injury to the brain. And so we can see calcifications, white matter injury, cerebral infarction, again, cortical dysplasias, heterotopias, and polymicrogyria, all those brain malformations that I worry about and see in my neurology practice can be because of this infection. There is no specific treatment for this, and so again, frequent hand washing to prevent infection, especially in pregnant women. So congenital toxo, always on our list of considering congenital infections. It can be asymptomatic at birth in quite a bit number of cases, and we know it can cause a significant neurologic conditions in the child. Intellectual disabilities, developmental delay, and then microcephaly and hydrocephalus that we talked about. And I want to show in this image below that the calcifications with this are really diffuse, as opposed to when we saw in the CMV case that it lines the ventricles. So congenital toxo is one also very important to consider because we do have a treatment for it. And so in the prenatal period when it's diagnosed, you diagnose it with serology. In the US, we have a specific lab we send it to in California. And the testing is actually very good for this virus. Treatment prenatally is spiromycin, which is very good at reducing the transmission from the mother to the fetus. And so 23% transmission in treated mothers compared to 60% of untreated mothers. Postnatal treatment is continued with pyrimethamine, sulfadiazine, and folinic acid for a year with close monitoring. And then we'll touch on our last infection here. So this is a case of fever and a rash illness in pregnancy. A woman, sorry. A woman who traveled to Belize and Guatemala and Cancun in her first trimester of pregnancy. After returning to the US, she developed an illness lasting 5 days with a low-grade fever, an erythematous maculopapular rash, myalgias, and photophobia. Her husband also developed similar symptoms. So after returning from her trip, obstetrical evaluation was normal. But then a few weeks later, while the ultrasound was still normal, she was assessed for Zika because of these symptoms, and these returned as positive. At 19 weeks gestation, which is now 7 weeks post-symptoms, the fetal ultrasound became abnormal, and she was referred to us for further evaluation. So this is a fetal MRI at 20 weeks gestation in this fetus. And this is actually probably the first reported fetal MRI of Zika virus infection. In this image on the left, which is a normal the case at 20 weeks gestation, we can see that the cerebral cortex is severely thin, especially in the frontal lobes, compared to the normal fetus at 20 weeks, where we have a nice thick cortex and a present lamination pattern. This is the same fetus at 20 weeks now on a sagittal image, and we can see that the corpus callosum is quite small in the image on the left compared to the normal corpus callosum in the image on the right. And actually, if you recall back to that CMV case that I showed you at the beginning, we actually have some similar findings between these two cases. And so this is from Zika virus. And so we know this is a virus fed by mosquitoes, and it is related to dengue and West Nile virus. This virus had actually been around for a very long time, but it wasn't until it caused a devastatingly high rate of microcephaly in Brazil that it was recognized to cause a congenital infection. And so congenital Zika syndrome is the severe clinical phenotype of congenital Zika infection. What we see is children, of course, with microcephaly because of very severe disruption to brain growth after the infection, hyper or hypotonia, arthrogryposis, developmental delays, ophthalmologic abnormalities, and sensorineural hearing loss. And it's about 5 to 12% risk after in utero infection. So there's very high risk for this very severe these manifestations. And what it seems mostly is that there is a very severe manifestation, such as what we're of this list here. But the other children that are exposed seem to do pretty well. And so there are some very unique features of congenital Zika syndrome compared to the other congenital infections. So they can have this abnormal skull shape, and this is because of a condition called fetal brain disruption sequence, where the brain growth or the halting of brain growth is so abrupt that the hydrostatic pressure of the brain inside the skull is altered so rapidly because of the destruction of the brain tissue that the skull collapses downward, causing this occipital protuberance. The cerebral calcifications in Zika are in the subcortical region, so different from the other congenital infections. They can also be in the basal ganglia region. And then Zika can cause arthrogryposis. None of the other congenital infections do this. Zika can also cause significant eye findings. So many different kinds of eye findings can occur. So chorioretinal atrophy, optic nerve abnormalities, iris colobomas, lens subluxation. There can also be sensorineural hearing loss, But unlike CMV, that is, it's either present at birth, but it does not occur later. They can also have seizures. They can also have cerebral infarctions or vasculopathies associated with the infection. And then, of course, there can be the other sensory polyneuropathies that are seen in older infants and children. And so here is a case that came to see us at 25 weeks gestation, showing all of these features of Congenital Zika Syndrome in the fetus. And so we have a very thin cortical mantle, a fetus with arthrogryposis. You can see ventriculomegaly because of the loss of the brain tissue. And this is the ultrasound growth curve of the head circumference, and it's below the curve. And so while we're not hearing much about Zika now, it is circulating in low levels in these same areas, Central and South America. And so we just need to be cognizant of thinking about it if we are seeing a baby with microcephaly and the family did travel. And so what I think important for us to be thinking about as we're moving forward from the Zika epidemic is certainly that, there are a number of babies affected at birth. So about the 10% of babies whose mothers had the infection in pregnancy have birth defects because of Zika, microcephaly, and these children will have abnormalities in their development. But what we're starting to understand now, and we have been working a lot on over the last couple of years, is of those healthy babies, or the 90% of babies whose mothers had Zika infection, are they going to go on to be affected and have differences in their neural development or stay healthy? And so data that I worked on in my group in Colombia and also in the US, is that these babies, at least at 18 months of age, were showing some signs of having lower neurodevelopmental scores, even though they were normal appearing children. And so just to highlight our congenital infection program, we have a multidisciplinary program with innovative research, a wonderful process for supporting these families throughout the pregnancy, and our advanced imaging. And we evaluate many different kinds of congenital infections in our program. I think they're all very important to consider as potential etiologies for a lot of the brain conditions that we see. And that is at the end. So, thank you.